everyone, and welcome to week 7 of Bitesize Ethics. Just to check, can someone do a thumbs up if they can hear me? Yay, great, thanks everyone. We are absolutely delighted to have our senior research fellow here with us today, Becky Brown. Becky's been at the centre now for a few years. She specialises in public health ethics, amongst other things, and particularly in public health communication. And I know a few of you have been interested in the wider projects of our speakers, so I'll pop details of Becky's most recent funded research in the chat in a minute, so you can have a quick look at that. And that is Honesty in Public Health Communication, which was funded by the Templeton Project. So Becky's going to be talking to us today about the ethics of medically unnecessary caesareans. Becky, if you're ready, I'll hand over to you.
Great, thanks, Liz. So I'll share my screen. Is that working okay? Can people see the?
We can see that, yep. Great,
slides?
thanks. We can see all the upcoming slides as well, if that's what you're intending, yeah.
That's not what I'm intending. Not that it matters hugely, but let me just...
No spoilers.
Try the same thing again. Is that any better?
It's bigger, we can still see the upcoming slides, but I think that works.
Yeah, okay.
Thanks.
You'll have the spoilers, but it's okay. Just try your best to pay attention to the current slide. But great, okay, thanks very much. It's nice to be here. I hope the previous sessions have been interesting and gone well. This is my first time doing one of these bite-sized ethics classes, so yeah, I'm looking forward to sharing this work with you and having a bit of a chat about what you think of it afterwards. So this is work that I've done with a colleague in Trinity College Dublin, so someone called Andrea Mulligan. So when I say we make various claims, that's who I'm talking about, is me and Andrea. And as the title indicates, it's about what are called maternal request caesarean sections. So these are caesarean sections that are performed because the woman would rather deliver by caesarean section than deliver vaginally, or to attempt a vaginal delivery. And there is quite a lot of debate about the ethics of providing these kinds of caesarean sections. So as Liz mentioned, a lot of my work focuses on kind of issues in public health ethics, and I've been particularly interested in public health communication recently. But then in 2021, this person came along. So this is my daughter, Una. And like quite a lot of people, I think, who...
Sorry, Becky, the slides aren't actually moving forwards.
Can you see a baby now?
We can, yes, thank you. Definitely worth it.
So this is Una. And I think quite a lot of people who experience childbirth firsthand, not as a baby, obviously, but as an adult, find it quite a I don't know how to say it, like a striking process, like a startling process. The reality of it is often quite surprising and quite intense. And given that I already work in medical ethics, I was quite interested to think about some of the ethical issues that arise in the context of pregnancy and childbirth, and the care of pregnant women before and during labour, and how the interests of women are traded off with the interests of the fetus or the baby, and all those kinds of issues. So I've been kind of interested in this for the last few years. And I think it's often the case that people who work in practical ethics are drawn to particular topics because they have some kind of personal relevance for them. So caesarean sections are often seen as an intervention to be used for particularly risky or difficult deliveries. So If a pregnancy is considered low risk, then the woman will be directed to deliver vaginally as the kind of default. So that's the majority of people would be expected to at least attempt a vaginal delivery. But there has been some movement in recent years to recognise that some people might prefer to deliver by caesarean section anyway. So even if they're not expected to have any particular difficulty delivering vaginally, they might nonetheless rather deliver by caesarean section. And this has been recognised in various guidelines, including in the UK. So in the UK, we have what are called the NICE guidelines, so the National Institute of Clinical Excellence, synthesizes evidence on the costs and benefits of different kinds of interventions, healthcare interventions, and then makes recommendations about best practice. And the guidelines around caesarean section delivery in the UK recommend that women should be given the opportunity to deliver by caesarean section, even in the absence of any clinical reason for doing so. So even if there's no particular risk factors that mean it would be safer for the woman to deliver by caesarean section, if she nonetheless prefers to deliver that way, then the guidelines operating in the UK recommend that her request is fulfilled. So this is effectively to say that maternal request caesarean sections are permitted in the UK. They're recommended under these guidelines if that's what the woman prefers. But NICE guidelines in the UK are not mandatory. So local healthcare providers do not have to do what the guidelines recommend. So that means they don't have to provide caesarean sections to women who request them in the absence of a clinical indication. And there's actually quite patchy provision of these maternal request caesarean sections in the UK. So a charity called Birthrights was trying to find out how much access women have to caesarean sections that are performed without a clinical indication. And they submitted freedom of information requests to the clinical commissioning groups all over the UK. And their findings suggested that about a quarter of trusts do provide maternal request caesarean sections. So if a pregnant woman says, I would like to deliver by C-section, even though I don't have any medical need to do so, then about a quarter of trusts will facilitate that. About 50% of trusts partially adhere. So that means that they maybe say that you can access maternal request caesarean sections, but in fact they've never actually done any, which is a bit suspicious. Or they say that you can access a maternal request caesarean section, but they have no kind of protocol or system in place for actually requesting one, and it's unclear how that would happen. So the Birthrights classified about 50% of trusts as falling into this kind of halfway house, where it looks like maybe you can access maternal request caesareans, but it's not obvious that people can reliably actually do so. And then there were another 15% of trusts which explicitly refused to perform maternal request caesarean sections. So these are data from 2018. I'm not sure what the picture is in 2024. I think it might be that there's slightly better provision of maternal request caesarean sections, because I know that at least the John Radcliffe Hospital used to refuse to do them. And in around 2021, I think they updated their own internal guidelines to say that they would perform them. So the picture might be slightly different today, but nonetheless, there is still places in the UK where you wouldn't be able to access a maternal request caesarean. Lots of other countries have a kind of similar approach to the UK. So most places will say, as long as the woman is fully informed of the risks and benefits of a caesarean versus a vaginal delivery, even if there's no clinical indication for a caesarean section, you should still provide her with one if that's what she really wants. Norway is a bit of an exception here. So the Norwegian guidelines say that you should not not provide a caesarean section if there is no clinical indication for doing so. But they are a slight outlier in most of Europe, in Australia, in most of the United States. You can access maternal request caesarean sections, at least in theory. Those are the guidelines. There's also a more general, we can kind of get an impression of what attitudes towards maternal request caesarean sections are by looking elsewhere, not just looking at guidelines, but looking at the published literature, looking at the discussion of maternal request caesarean sections. And what we see here is that although the guidelines mostly recommend supporting women if they request a caesarean section without clinical indication, much of the discussion about caesarean sections is quite concerned about high rates of caesarean section, is focusing on methods of reducing the number of caesarean sections that are being performed. And there's a general kind of negativity towards caesarean sections, particularly in the context of maternal requests and no clinical indication for doing them. The World Health Organization was kind of talking about an epidemic of caesarean sections. They used to recommend that countries try and keep their caesarean section rates below a certain level, so they had a kind of benchmark for what they thought was an acceptable frequency of caesarean section deliveries. Now that's been heavily criticized, but nonetheless, that's kind of been the prevailing attitude, is that ideally we shouldn't be performing caesarean sections unless it's really necessary, and that the fewer caesarean sections being performed, the better. It's also quite hard to know how many caesarean sections are performed as a result of maternal request. So it's not always particularly well documented. And there's also probably a lot of women who would request a caesarean section if they felt like they had the opportunity to do so. So it's quite hard to know what numbers of women would prefer to deliver by caesarean section if it was available. And we just don't have good data on that at the moment. So with my colleague Andrea, we have argued that planned caesarean sections should be routinely offered to women who are expected to deliver with low-risk pregnancies. So our recommendation is slightly different from the current recommendation in the UK guidelines. So to remind you, the UK guidelines say if a woman spontaneously requests a caesarean section, even if there's no medical reason for performing one, she should be facilitated to have one if at all possible. And what we're saying is women shouldn't have to spontaneously request a caesarean section themselves. It should be part of the discussion when they're attending their routine antenatal appointments anyway. So it should be raised as an option for giving birth alongside vaginal delivery from the outset. So why do we think that this is a preferable way of dealing with women's birthing options, of kind of having these discussions about the option of delivering via caesarean section, even if there's no clinical indication for doing so? So there's three main reasons that we put forward for thinking that women should just be offered caesarean sections routinely, even if they've got low-risk pregnancies. So the first one is that we think that maternal request caesarean sections are a medically reasonable option, a medically reasonable way of delivering a baby. So we don't think that a caesarean section has to be necessary in order for it to be appropriate to perform one in order to deliver a baby. So it just needs to be a reasonable option, right? Like it needs to meet some kind of threshold of clinical harm versus benefit, so that it's not loads worse than other ways of delivering. Now, the evidence about the harms and benefits of delivering by caesarean section versus attempted vaginal delivery is is not of great quality. So one issue that we have with the evidence is that it tends to lump together all sorts of different kinds of caesarean section. And it's not very good at teasing out the effects of having a maternal request caesarean section as opposed to having an emergency caesarean section or a planned caesarean section that's performed because there are particular risks in that pregnancy. So if somebody has an emergency caesarean section, this means that they have attempted to deliver vaginally, but for whatever reason, perhaps labour isn't progressing as it should, perhaps the baby is stuck, perhaps the cord has got caught around the baby's neck, perhaps there's concerns about the baby's heart rate. There's loads and loads of reasons why a call might be made during attempted vaginal delivery to switch to a caesarean section. And if that decision is made after the onset of labour, then we describe that as an emergency caesarean section. And understandably, the outcomes of emergency caesarean sections tend to be a bit worse than vaginal deliveries. But these are deliveries where something has gone a bit wrong during labour. So not necessarily catastrophically wrong at all, but something has gone a bit wrong. So what you tend to see is that the outcomes for babies and for women after emergency caesareans tend to be a bit worse than after vaginal deliveries. The other set of caesarean sections that we need to think about are elective caesareans, planned caesarean sections that are performed because there's a particular risk involved in this pregnancy or this delivery. So it could be that the baby is breech, so is coming out bum first rather than head first. It could be that the woman is delivering twins. It could be that the baby is small for gestational age and they're concerned about its ability to withstand a vaginal delivery, or there could be any number of reasons, again, why a caesarean section is planned rather than delivering vaginally. But this tends to happen in higher risk pregnancies. So again, the outcomes for the mother and the baby in the context of elective caesarean sections that are done because there's a particular risk present tend to be a bit worse than the outcomes when people deliver vaginally, which tend to be low risk pregnancies. But if we think about maternal request caesarean sections, this is specifically, these are performed in pregnancies where they are necessarily low risks, where the caesarean section is not clinically indicated. So these are cases where it would be perfectly acceptable for the woman to attempt to deliver vaginally. So we should expect the outcomes in these kinds of deliveries for these women and these babies to be much more comparable to vaginal deliveries. But what we have is the data for all the caesarean sections is often lumped together. So you get the plan for a particular risk factor, caesareans alongside the emergency caesareans, alongside the low risk maternal request caesarean sections. And so you get this kind of pollution of the data that I think makes the maternal request caesareans look riskier than they in fact are. And when you are careful to kind of try and tease out the effects associated with these different kinds of caesarean sections, then the outcomes associated with maternal request caesareans actually look very similar to those of vaginal deliveries. So the outcomes in the case of maternal request caesarean sections are different. There are different risks associated with caesarean section than those associated with vaginal delivery, but we can say something like they're comparable. So in the case of caesarean section, you might be at higher risk of experiencing longer term, more moderate pain as you recover from the surgery. Whereas in vaginal delivery, you're at risk of experiencing shorter term, much more acute pain as you go through contractions and vaginal delivery. Caesarean sections have risks after surgery of things like the wound can become infected, but vaginal delivery has higher risks of things like incontinence, urinary and fecal incontinence, of experiencing tears, and kind of longer term problems as a result of those kinds of complications. So there are different risks associated with caesarean section and vaginal delivery, but it's not clear that either set of risks is preferable to the other. And so this sometimes gets described in medical ethics as a preference-sensitive decision. So the only person that can say which set of risks they would like to be exposed to is the person who's actually going to experience those risks themselves. So in this case, it's the woman who's going to go through labour, who's going to deliver the baby. So she is the one who can say whether she prefers to experience the risks associated with caesarean section or the risks associated with vaginal delivery. So this brings us on to the second point that I've got on this slide, for why planned caesarean sections should be routinely offered to women expecting to deliver low-risk pregnancies. So we think that the woman should get the opportunity to choose which kind of injury she experiences during delivery. So this is a kind of a reasonably gruesome thing to think about and a way of putting it, but basically childbirth inevitably results in some kind of injury. People do not go through childbirth completely unscathed. The scale of the injury varies hugely. So it starts off at one end with like small grazes during vaginal delivery to really catastrophic, life-changing, and perhaps even life-threatening injuries that can occur with deliveries that go really wrong. The opposition to caesarean sections is often framed as protecting women from the serious injury associated with a C-section. So people who are opposed to performing maternal request caesarean sections will say, this is major surgery. It's cutting into the abdomen. It's not something trivial. It should only be done in cases where there's a really serious risk of harm if it's not performed. But this seems to overlook the injuries that can occur during vaginal delivery, and it seems to downplay the significance of the injuries that people can experience during vaginal delivery. So current practice in the context of women's choices about how to deliver their baby tend to assume, if it's a low-risk pregnancy, that vaginal delivery is in women's best interests. And then this is the only option that's presented to them. So it's just assumed that they will do better if they deliver vaginally, and so no other options are mentioned to them. But this isn't really how disclosure is expected to operate in much of medicine. So what we would ordinarily think is appropriate is for the clinical team to present whatever the reasonable options are to the patient. So there might be option A, option B, option C, and they'll say, look, we think that in your case, option A is probably the best one, but option B and option C are also reasonable if you prefer them for any particular reason. But this isn't what happens in the context of childbirth. So option B is never presented. Only option A is presented. And so we think that this is inappropriate, that right from the outset, women should be told about the kinds of injuries that they can expect to experience if they attempt a vaginal delivery versus if they undergo a planned caesarean section. And then they should be the ones who, in discussion with their clinical care team, make the call about which kinds of injuries they prefer to be exposed to. So the final point that we wanted to make in support of this idea that planned caesareans should be offered to women routinely is that medical necessity isn't a particularly helpful way of thinking about what kind of care is appropriate. So often the argument against maternal request caesarean sections is just to say, well, it's not needed, it's not medically necessary. But it looks like medical necessity isn't something that we should be focusing on when we're thinking about what kind of care is appropriate for people. So it doesn't establish that care must be provided. So even when a clinical team thinks that a particular course of action is necessary or is appropriate, the patient can always refuse it. and so long as they're considered competent to make that decision, their wishes will be respected. So medical necessity doesn't show us instances where a particular kind of clinical care must be provided. And it also doesn't rule out clinical care when medical necessity is absent. So there are many reasons why someone might prefer to deliver by caesarean section rather than vaginal delivery. And we might frame those reasons as medical, or we might consider them to be kind of reasons that don't relate to someone's health or don't seem to be medical in nature. So quite a lot of people that end up requesting caesarean sections and who are labelled as not having any clinical indication for caesarean section, these people might have experienced something like sexual trauma in the past. They might be experiencing severe pelvic pain during pregnancy, and they might be concerned about the kinds of exacerbations that vaginal delivery could result in for that pelvic pain, or the kinds of re-traumatization they might experience if they deliver vaginally. Now, these aren't obviously not clinical reasons for preferring a caesarean section. They kind of do seem like they relate to someone's health, perhaps their mental health. So it's not obvious that we should exclude those kinds of reasons from being considered medical reasons for wanting a caesarean section. But nonetheless, they typically are considered not medical reasons, not resulting in a kind of clinical indication. And then there are additional, so there are these reasons which aren't treated as medical reasons, but actually that seems like a slightly strange decision not to treat them as medical reasons. Then there are other reasons which seem much more uncontroversially to not be medical. So it might be that someone has particular caring obligations that mean it's extremely important for them to be able to arrange alternative care whilst they're delivering their baby. And those kinds of reasons don't look clinical. Those don't look like medical reasons, but they also don't look trivial. So it's not unimportant that somebody might not have other care options available for their older child when they're delivering a baby. They can't just abandon their child, right? Like being able to plan when you're going to deliver and make sure that you've got contingencies in place is really, really important for people. And there's a tendency to dismiss all of these reasons that aren't seen as clinical, that aren't seen as medical reasons for having a caesarean section, and to treat them as if they're kind of frivolous or trivial or don't deserve to have any attention paid to them. And we think that that's a mistake. So those are our main reasons for thinking that planned caesarean section should be routinely offered to women with low-risk pregnancies. It's worth just running through a few of the objections that people might raise to this kind of a proposal. So the first one is the idea that patients have a right to refuse treatment, but not to demand their preferred treatment. So this is something that people will commonly point to in the context of disputes about what kinds of medical care are appropriate to provide, what kinds of treatment doctors are obligated to provide for patients. So there is quite strong legal protection over doctors' professional integrity. So doctors will not be obliged to provide treatment that they deem inappropriate. But as I've tried to show, there isn't really anything clinically inappropriate about providing a maternal request caesarean section. So the harms and benefits associated with a maternal request caesarean section are sufficiently similar to those associated with vaginal delivery. Not least, I should have mentioned this before, but it's extremely relevant that many people who opt to attempt to deliver vaginally end up delivering by caesarean section anyway, because of the reasons I mentioned before. Maybe labour isn't progressing appropriately, maybe there's signs of fetal distress, maybe the woman is struggling to push the baby out and they're not able to extract using forceps. So actually attempting to deliver vaginally doesn't mean that you will deliver vaginally. It's reasonably likely that you'll end up having a cesarean section anyway. In low risk pregnancies in Britain, it's about 1 in 5 women that attempt vaginal delivery end up delivering by cesarean section anyway. So you're reasonably likely to end up experiencing the downsides of both vaginal delivery and cesarean section if you end up having to have an emergency cesarean section. So it looks pretty reasonable to actually opt for a planned cesarean section in the first place. So it doesn't seem like this is one of those cases where patients are requesting something completely inappropriate and it would undermine the clinical team's professional integrity in order to provide the treatment that's being requested. A second objection is that there's a risk that women will feel pressured to deliver by a cesarean section if we kind of routinize offering planned cesarean sections during antenatal appointments, even in the absence of clinical indications. So as I mentioned before, there's widespread concern about high rates of cesarean sections. In some places, cesarean section is being used at extremely high rates. So Brazil is one place where in private hospitals, at least, delivery by cesarean section is much more common than delivery than vaginal delivery. And it looks like the reasons for this are quite troubling. There are financial incentives for the clinical team to prefer delivering by cesarean section. There might be misunderstandings amongst the women in terms of the harms and benefits associated with different modes of birth. So this doesn't look like something to aspire to, and there's some concern that if cesarean sections are offered as the norm, or as a kind of a more normalized option, then women who would otherwise be quite happy to deliver vaginally might feel like they're being encouraged to opt for a cesarean section, or it might become stigmatized to deliver vaginally, or those kinds of things might result. So I think this is a worthwhile concern. It's something to consider carefully. It's hard to predict what the effects will be if we change practice and we started offering cesarean sections to women routinely. But it does look like the response to this should be something like, well, if this were to occur, the problem would be that women's preferences are not being respected, or they're not really given the opportunity to choose for themselves and to understand what's in their own interests and their baby's interests and to make decisions accordingly. But our response to that shouldn't be to further restrict women's choices, right? It shouldn't be to say, oh, well, women can't make these decisions themselves, so we're going to decide for them. It looks like the response should be to really take care to try and ensure the women's choices are genuinely available and appropriately informed. So to try and address any misunderstandings that might arise, to try and ensure that women don't feel inappropriate pressure to deliver one way rather than another, and to really kind of take care during those early discussions about mode of birth, about how women are going to plan their deliveries. The final objection is that routinely offering planned cesarean sections will result in large increases in the number of cesarean deliveries, which we can't afford. So this is a common worry, that cesarean sections are much more expensive than vaginal deliveries, and that it would just cost the NHS much too much to justify their routine provision. So this is a kind of a difficult objection to respond to with a great deal of confidence, because it is hard to say whether routinely offering cesarean sections to women with low-risk pregnancies would result in significant increases in the number of cesarean sections that are being performed. We don't really know what would happen. If there were large increases, then undoubtedly in the short term, the NHS would not be able to cope with that. There are insufficient operating theatres, there are probably too few anaesthetists available. It's not something that could be accommodated immediately. So this objection certainly points to a need to make significant changes to the existing NHS resources in maternity centres in order to actually provide the care that people would be requesting. So this isn't something that could be suddenly introduced overnight. There would have to be some kind of phased introduction, and there would need to be a lot of other changes made in order to facilitate it. In terms of the overall cost to the NHS, though, caesarean sections are not actually considered that much more expensive than vaginal deliveries, partly because, as I mentioned, quite a lot of vaginal deliveries end up being caesarean sections anyway, and partly because of the difference in the cost of the aftercare required. So when you factor in treatment for incontinence, which occurs at a higher rate amongst women who deliver vaginally, then the additional cost of caesarean sections is actually estimated to only be about an extra £84 per delivery. So this is according to the economic modelling that NICE performed as part of their guidelines. So this is a very surprising number to me and to lots of people. You would assume that the cost of a caesarean section, which involve, a surgical theatre, a much larger team being present, women have to stay in hospital for longer afterwards, typically. You'd think that would all mean that caesarean sections are much, much, much more expensive than vaginal deliveries. And in the short term, they are more expensive. But incontinence is an extremely common side effect of delivering vaginally. And it's women experience incontinence at a higher rate, probably as a result of pregnancy anyway. So incontinence is associated with caesarean section delivery as well, but just at much lower rates. And so when you factor in the treatment for incontinence after delivery, it ends up women who deliver vaginally end up costing much, much more to the NHS than women who deliver caesarean sections. So it means that the kind of the difference in cost of these two modes of birth are actually not so different. So like I say, £84 per delivery is the estimate. So this objection would be very serious if caesarean sections actually did result in much greater costs. But at least for people with low risk pregnancies delivering by caesarean section, it looks unlikely to be the case. So that's really all that I wanted to say.